excuse me. Good afternoon, everyone. Welcome to this meeting of the Health and Government Operations Committee. Please bear with us if we encounter any technological issues. This meeting is being streamed on the Maryland General Assembly's YouTube channel. Committee members will be muted during the briefings. Following the presentation, please use the raise hand function if you want to ask a question. I will call on delegates to ask questions. When it's your turn, please wait a moment while staff unmutes your screen. Keep in mind that even though we're meeting on Zoom, we'll adhere to our usual committee rules of asking one brief, concise question and receiving an answer from one, not each of the panelists. First, we'll have an update from the Maryland Reinsurance Program by Michelle Eberly, Executive Director. Then there will be an update on the Maryland Health Equity Resource Act of 2021. Presenting will be the Honorable Ed Casemeyer. I think I'll introduce the people again when we get there. The last briefing will be an update on the Maryland Commission on Health Equity, the Shirley Nathan Pulliam Act of 2021. So we will start right now by asking Michelle if she would please brief us.
Well, good afternoon, Chair Pendergrass and Vice Chair Pena Melnick and committee members. Thank you for inviting us here to give an update on the reinsurance program. And you have me only this time. Johanna Fabian Marks, our policy director, gave birth to her first child, a little baby girl, in November. And so she's off on maternity leave until the beginning of February. So you won't have as eloquent a presentation as you have from her, but you'll have to suffer with me through this. We'll continue on. Next slide, please. So what I want to do today is just give you an update on the program performance for the plan year 2021, the reinsurance program, what the costs and the funding and enrollment has been so far, the reinsurance parameters we put in place, and then the waiver timeline as we look to going forward, along with the carrier accountability reports. Some of this you may have seen in other presentations, and we've tried to update it where it's relevant. So we'll continue on, please, to the next slide. And you can, there we go, perfect. Premiums, as you can see, have continued to fall. And what's really great news, and it's not reflected on this chart, but for 2022, we still see that our rates are going to be very competitive. So when we put the reinsurance program in place, the intent was to really have a 30% reduction in rates over a 3-year period. We actually surpassed that, and we've seen a 32% reduction in rates since the reinsurance program has taken place. And you can see from our history, starting in 2024, we had pretty modest increases, and that was when there was still some federal reinsurance funding available. Once that reinsurance funding went away, you can see the dramatic spike in the cost of insurance premiums. Once the state reinsurance plan was put into place, we did start to see that decline of rates being lowered. Now, for the 2022 plan year, although we saw a slight increase in premium rates of 2.1%, I'm really happy to report that Kaiser Family Foundation has reported that nationally, Maryland's bronze and gold plans have the lowest premium in the nation, and our silver plans are the 3rd lowest behind New Hampshire and Minnesota. So the effects of our reinsurance program really continues to help. One other point I wanted to make is that we had planned on that 30% reduction over a 3-year period of time, and then future changes tied to claims trends. So we're seeing that now with this 2.1% increase. Next slide, please. This just shows you, again, our increase or how much lower we are than the average lowest cost premiums in the nation. And as I did just state, we have the lowest in bronze and lowest in gold in the nation. Just to give you kind of an example of what that is for plan year 2022, you can see it through 2021, but for plan year 2022, our average cost of the bronze plan will be $221, and that's before the APTC or the young adult subsidy, which we have. The US average is $329, so it's quite a significant difference. Likewise, for the silver plan, our average is $328 for plan year 2022. The US average is $438. And the gold plan for Maryland, the average price is $296, and the US average is $462. So not only are we the lowest, but we are significantly lower on a monthly basis. Next slide, please. On this slide, you just see a more detailed breakdown of the estimated effect of the reinsurance program on each carrier. And we can see without reinsurance, we could have expected rates to increase by an average of 23% or more, depending on the carrier. Whereas with reinsurance, we saw that each carrier had at least 11% decrease in the premiums. For 2022 premium rates, we do see the leveling off of reinsurance and the impact of claim trends. The rate filing for 2022, what MIA found is that the carrier's aggregate estimate for enrollment was 9% higher with insurance. That's what the carriers filed, was their estimate. And lower morbidity was also another finding. The additional members that have come into the pool are healthier on average and improve the morbidity of the pool. The carriers in aggregate estimated about a 6.5% improvement to morbidity of their membership. For plan year 2022 with reinsurance, the Care First HMO plans are up 6.2%. The Care First PPO plans are down 12.6%. Kaiser Permanente plans are down 5%, and the United Healthcare plans are up 1.2%. So that's where we get on average the 2.1% increase. Next slide, please. Our enrollment continues to increase. Last year, we had the best enrollment ever that we had, so that's really exciting. We're continuing to see that trend for plan year 2022. Currently, our enrollment on exchange is trending about 7% higher than last year. And this year is a little different in that we will have open enrollment through January 15th. So in line with what the federal government has done with extending the open enrollment period, we will be doing so as well. Next slide, please. Looking at our hypothetical situation where we did not have reinsurance and where we don't have lower premiums, we estimated that our enrollment would have been about 18% lower. So not only have we not realized that, but we really are seeing continued growth in our enrollment through the reinsurance program. Next slide, please. So let's switch, and you can move on to the next slide. Let's talk about the program's performance in 2021. In 2020, we had total enrollment in the individual market on and off exchange was about 2.5 million member months, or about 212 individuals. About 6% of those enrollees had annual claims that met the parameters for the reimbursement under the state reinsurance program. We won't have 2021 plan year information until the fall of 2022. The way the cycle works and where the carriers report, it's a little delayed, but this gives you the 2020 actuals. Next slide, please. When we look for the 22 or 2020 plan year, what we see is that the total claims paid in 2020 were about 1.2 billion. 94% of enrollees who did not qualify for reinsurance payments accounted for 33% of the paid claims. The 6% of enrollees who qualified for reinsurance payments accounted for 67% of paid claims. That's not unusual. Usually whenever the carriers will talk about their costs, there's a very small percentage that consume the most paid claims. Now of that, those 67% of the paid claims, the reinsurance program reimbursed half of those claims, accounting for 33% of the total paid claims. The insurers covered the other 34% of those claims. So by the state reinsurance program funding a third of those high cost claims, it allows us again to reduce premiums for everyone. Next slide, please. This just gives you an indication of the payments by carrier and the impact of the dampening factor, which I'm not going to go into today. But again, you can see 2019 and 2021, the impact that this had for reducing costs on the carriers, for the carriers. Next slide, please. This slide looks pretty busy, and I'm going to walk through it and talk about the actuarial and projected reinsurance fund expenses and income with the American Rescue Plan funding and then without. So this first one assumes that the American Rescue Plan funding ends in 2022. And just to give you a brief update on that, when the American Rescue Plan Act went into place, it allowed for enhanced tax credits, which is providing more funding for consumers to get tax credits, and eliminated the 400% threshold whereby you could no longer get tax credits. So that eliminated that. It right now runs for the plan year 2022 and 2023. There is legislation in the Build Back Better Act right now that would extend that through 2025, but we'll wait to see what happens with that. So to explain what you're looking at here, the top line, the SRP costs, that's what we've either actually paid for reinsurance program or the estimated costs that the actuaries determine that we will need to pay. So you can see those costs have continued to grow, and which is not unexpected as our enrollment has continued to grow. The next several boxes, the next 4 boxes, are areas where there have been legislatively mandated reductions in the funding that we have. So for 2021 and 2022, there was $100 million rather transferred to the Medicaid budget for those 2 years. The Young Adult Subsidy Program, we funded with $20 million for 2022 and 2023. The RX Affordability, which is the Senior Drug Assistance Program, had a little budget shortfall, so that was filled with $1.9 million from the Reinsurance Fund. And then the Health Equity Resource Commission was funded with $8 million for 2022 and $23 million for 2023. And that includes $15 million for the Health Equity Resource Community Grant Programs, and then $8 million to administer those grants. So that's where that money is funded. The next 2 green lines show the incoming federal funding, what was actual and what was estimated. This year, for 2020, we had actually estimated less money to be received by the federal government, and we actually received additional money. We don't know yet how that will play out in additional years, and so we have that funding as what we believe we'll get as a pass-through, but again, that's always subject to change. The state funding comes from the first year in 2019 was a 2.75% assessment on issuers that was in lieu of the federal health insurance fee. And when that went away, then we implemented that for 2019. Subsequent to that, we had a 1% assessment for 2020 through 2023 to help fund the reinsurance program. And as you'll recall, we are not able to have the state reinsurance program without some match of state funding. And so that's the state funding that we have through 2023. Finally, you'll see where the estimates are, excuse me, for funding balance that would be available through the end of each year. Next slide, please. I want to talk a little bit about the reinsurance parameters that the board has set. So each year, the Board of Trustees, in conjunction with the Insurance Commission and the MIA, looks at where our attachment points are. That means where before the program will kick in and provide funding, what that co-insurance rate will be for that interim in the amount of claims, and then what the cap is. We have held for the 4 years of this program now, the attachment point at $20,000, the co-insurance rate at 80%, and the cap at $250,000. That is a very generous reinsurance program nationally, and it has allowed us to have such significant reduction in premium. So we're pretty pleased with that. The dampening factor, I will talk a little bit here. That's a factor that is determined by the Maryland Insurance Administration, and it's applied to reinsurance funding to help accommodate for funds that come from the federal government for risk adjustment. So it just helps balance out and make sure that a carrier is essentially not getting paid twice for the same person with the same type of condition. So there's some mathematics that goes into determining how to do that to best make sure that the reimbursements are equally distributed. Next slide, please. I want to talk a little bit about the next waiver timeline. As you will recall, this program is a 5-year program. We need to go back to CMS with a request to continue the program if that's what we so choose to do for another 5 years. This timeline has been put in place to really give us a maximum flexibility and time to approach CMS and get our approval. So if we amend and extend the existing waiver, we need to submit our letter of intent 15 months prior to the waiver's amendments proposed legislation date. And that waiver amendment application by the end of the first quarter of the year prior to the year the amendment would take place. So we would need to just give heads up to CMS in calendar year 2022 that we are going to submit the waiver. And then by the end of the first quarter of 2023, we actually need to submit that application, the amendment application to CMS. Typically, it takes CMS, they could take up to 7.5 months for them to go through their whole process. But the way that operates when we submit a application, we have to put it out for public comment. We then submit it to CMS. They have technically 180 days to make a decision. It has not taken that long. It did not take that long the first time. So this timeline kind of accounts for all that. Ideally, between January and April of 22, we would like the General Assembly to determine whether to extend state funding for the waiver program. Between March and June of 2022, we would draft the letter of intent. July of 2022, the board would authorize MHB to submit the letter of intent. And by September of 2022, we would submit the letter of intent. Then between January and February of 2023, the board would authorize staff to submit the application. By February 2023, ideally, we would submit the application If there was any necessary legislation that needed to take place, we would still have time to do that. And then we would work with CMS to approve the waiver and start the new 5-year period in January of 2024. So that's the ideal timeline. Next slide, please. So when we talk about what we're looking at for the next program and what we need to do, it would be for a period of 2024 to 2025. We would again look at approximately that that attachment point, where that should be, if it should be at 20,000 or modified. The modeled rate impact indicates that for approximately 1% increase for every $1,000 increase in the attachment point, that's at $20,000 attachment point, that's what we would see, a 1% increase in premium rate. So say we increased that attachment point from 20 to 25,000, that might result in a 5% rate increase. But again, these are all things that will be modeled by the actuarial firm to give us exact numbers. ARPA continues to be, questionable. We don't know right now what that will do in terms of that will continue with the enhanced subsidies or not. Hopefully we'll find out soon. We're monitoring the Build Back Business legislation very close, Build Back Better legislation closely. If we hope to hear this year, may be pushed into next year. Next slide, please. And some of the considerations for the legislature and for the Board of Trustees to make when we look at this second waiver is, should we raise that attachment point? How much should it be raised? What will the ARPA subsidies, how long we will have them, how much they will be, how long will they be in effect? And then the plan for requesting the extension. So those are some of the things we're considering. Next slide, please. Do you have a next slide, or is that it on your deck? Okay, that's it. Good. There are some others in a deck I was looking at, which I'll just mention. The other piece of this that is not in the slide deck, but I'll just speak to a little bit, is that part of this program we have also is carrier accountability reports. So we are working with the insurance carriers for them to demonstrate to us and show how we are saving money in terms of claim costs. Because the reinsurance is based on paying medical claims, we want to make sure that the insurance carriers are really doing everything they can to contain those costs. And we have annual accountability reports. We've now received them for 2 years. So we have the baseline report and we have our secondary report, and we'll be putting together some analysis of the outcomes of those reports, and that will be forthcoming. And I'll end my briefing there and be happy to take any questions.
I see Delegate Krebs, you have your hand up.
Thank you, Madam Chair. And thank you. It's a very positive report about the Reinsurance Fund. But if I remember this correctly, we were subsidizing this group of folks to try to get the pool to be bigger. And if you would remind us, I mean, this is all good news, but remind us of where the money is coming from, who's paying for this, it's subsidized by other ratepayers, and what has been the impact on their rates, the people that are subsidizing these rates?
So the way that the assessment works is that it is a 1% assessment on, I believe it's net revenue of certain medical issuers and the MCOs. And so from that, we take that funding and we are able then to use it and match or use the federal pass-through dollars. So we get substantial amount of money from the federal government for what they would have paid for tax credits, but for the fact that we've lowered those premium rates. So because of that, we get significant, to the tune of $400 million in federal pass-through funding. And then with the state funds, we've been able to apply $100 million towards that to help keep those costs down. And the way the program works is CMS requires that the state be able to fund the program absent any federal funding.
I'm not sure I understand. You said the 1% assessments on net revenue of medical insurers. I've been under the impression and been told that it's people that are in the small group market and individual market they're actually having to pay this. Tell me where that money, that assessment of net revenue actually comes from, and does it impact anyone else's rates? That's what I'm trying to get the answer to.
Delegate Krebs, I will have to get back to you on that. I'd have to look at the precise legislation. I don't know off the top of my head the exact issuers that are affected by that. And I could not state whether because of that 1% assessment, they all have raised their rates to account for that 1% assessment. We'd have to pull each and every carrier, or maybe the MIA has a factor in their rate setting. So I couldn't address how that has affected their rates. And I can pull the legislation to tell you exactly who is being.
No, thank you very much, because that's a key piece to me, is how much is it affecting the people that are paying for it. Thank you very much.
Delegate Cullison is next, followed by Delegate Hill.
Thank you very much, Madam Chair. Michelle, you are extraordinarily organized and wonderful in presenting. So thank you so much for the information. So I saw the timeline, and then I saw the things that the legislature has to consider in moving forward with the reinsurance program, which to me are 4 fairly significant areas, and that we need a lot of data to be able to process. So I guess my question is, the timeline that you presented, is that an ideal timeline or is it a must-have timeline? And are we going to have to make all those decisions between January and April this year in this session, or do we have any leeway, and can we do that and have that ready for the 2023 session?
Thank you for that question. And let me clarify a little bit, because the only decision that would need to be made by the legislature at this time would be on that assessment, because that expires in 2023. And so at minimum, to extend that beyond 2023 for the program to continue beyond 2023. So probably from your perspective, the decision would be, what percentage and the duration. The other items that I spoke about, the attachment point, those are considerations for the Board of Trustees to make, not the legislature. So I want to clarify that they would be making any decisions around the parameters of the program. But the legislation that expires or sunsets in 2023, the 2 key factors are the timeline and the amount. And in answer to your question, it could go into 2023 session. The impact that would have would be two impacts. One, it would crunch the time that the exchange would need to get everything in, because it would probably have to be an emergency bill just by the timing, the timeline for filing. More important, the insurance carriers are required to file their rates by small group rates by March and individual rates by May. So if they're filing their rates for 2024, they have to file those by March and May of 2023. And that would be right during that session.
Okay, great. Thank you very much, Michelle. Thank you, Madam Chair.
You're very welcome. Delegate Hill, followed by Delegate Kerr.
Thank you. Thank you, Michelle, for that very comprehensive presentation. So I want to be clear that it sounds like that it's already a given that based on, and I think it's just based on what we're seeing the premium rates at versus the national, that the decision has been made that we ought to extend the waiver. And is that right, that's the decision that's been, I mean, you talked about parameters that we'd have to decide on how to extend it, or the board would decide on the specifics of what we're requesting. But what I heard in that is a conclusion that the decision is that it should be extended. And I'm assuming that's just based on the premium levels and that goal. Is that right?
Well, if you're asking for, is this program been successful and has it done exactly what it was set out to do? The answer is yes.
Okay.
So the decision of whether to continue the program or not would be based on whether there's any new information that might alter what would happen if absent the program. And I don't have any of that information other than to say that the program as it is in place today is very successful in doing what we intended it to do.
Okay, and the only negative might be what Delegate Krebs is asking about, that we might have to weigh, is that if it's actually rolling back to small group folks and they're picking up something significant, that might be a consideration. But from your standpoint, there are no other potential negating considerations to moving forward with an extension.
Correct. The program has been successful in doing what it was intended to do. Now, of course, there could be a lot of dialogue of, do we want it to do something different? Is there other different programs? But as the reinsurance program was designed and implemented, it's been very successful.
Okay, thank you. Maybe offline we can go over that slide 13 with the income and the outcome. I'd love to see that in a little bit more depth. Thank you. Thank you, Madam Chair.
You're very welcome. Delegate Kerr, followed by Delegate Kelly, who will be the last questioner of this panel.
Thank you, Madam Chair. Michelle, I have a question about the young adult subsidies. I know it's early and we might not know anything yet, but is there any indication yet, or what is your anticipation about how this program could lower premiums or affect the reinsurance program?
Well, first, Delegate Kerr, thank you for the work you did on passing that legislation. So we are seeing initially out the gate that it's doing very well. What we were able to do is take everyone who already was enrolled, and we were renewing, and apply that young adult subsidy, which on average is about $36 a month, to those folks that we already had enrolled, so we could keep their retention of them. And then in addition to that, we are now seeing, I think I looked today and it was about over 4,500 young adults that have newly enrolled. So that we're pretty happy with that. Of course, we do know just by the dynamics of this age group, many wait till the last minute to enroll. So December 31st is the last day to enroll for 1/1 coverage. We expect to see a spike then. And then just January 15th is a deadline for February 1st coverage, and we would expect to see another spike at that time too. But so far we have enough money to cover those folks coming in. So I think we'll be good there. And it looks like it's doing what we wanted it to do.
Well, thank you. Let's hope that continues. And thank you, Madam Chair.
Very welcome. Delegate Kelly for the last bite at the apple.
Thank you, Madam Chair. And I'm sorry, my dog is very loud today. I apologize. My question for Michelle, thank you for the work you've been doing. Hold on. Shirley, stop it. Thank you so much for your work. Okay, hold on. I'm putting myself on. I might pass my question because someone's making a delivery. Oh, wait, no. Okay, good. She's done. Thank you for your work. My question is related to the numbers you gave us on the gold plan. I think I did quick math, and it looks like on average, if you were to buy a gold plan on the individual market, you would be saving about $2,000 a year from the national cost, right? That ours would be $3,500 roughly a year, and the national average would be $5,500. So it's that big of a difference, right? I'm seeing you nodding. So my follow-up is, and in advance of your work on this, thank you so much for meeting earlier this week with me and the childcare providers. And I'm thinking of the the other workforce issues we have on HGO, the home healthcare workers, many of whom are contractors and uninsured, other folks who don't have access to a group plan, and the real meaningful impact that this program can have on our low-income healthcare workforce. So I just thought it would be nice if you could talk just a little bit about, you know, if for a gold plan, we're looking at people saving $2,000 a year, you know, what kind of work we can be doing with the exchange to help with the low income healthcare workforce and other caregiving workforce, sort of related to that meeting we had earlier this week, because I'm so excited about this.
And thank you for that introduction and that meeting, because it was a very fruitful meeting. One item I want to point out is that number is before APTC or the young adult subsidy, so it could even be greater. But we did have a subsequent meeting with the Child Care Workers Associations, and this is a perfect example of where we can work with existing resources across the state to get the message out of what's available for individual insurance. I'm always well, one of the comments I get frequently is the insurance is way too expensive and the deductibles are too high. And so that it still is a prevailing belief. And so what we'll generally do is sit down and say, all right, let me put in an estimate. Give me your parameters. I did this actually with the Farm Bureau Association with their CEO to say, give me your parameters. Let's look at it. We did this with the Child Care Workers Association. Let's pick for them, we actually did Anne Arundel County, 27-year-olds. So they'd be off their parents' plan and making $26,000 a year. And look, here's coverage, that good coverage they could get for $10 a month. So that's the type of thing people are always surprised. What we are doing in that effort, we're actually having a meeting next Wednesday, and I pulled in our marketing and our small business folks and our consumer assistants to say, how can we get the word out through your associations? Can we give you materials that you can co-brand? Can we help with getting people do healthcare fairs? Get you connected with producers? What can we do? Can we look at small businesses? Do you want to do an ICRA? Do you want to do a traditional small business plan? Do you want to guide people to the individual market? So how can we help you? There's lots of affordable health plans out there, and what can we do for you? And I think the associations, whether it's a restaurant association, the home health care workers, the child care workers, that we really have an opportunity to continue to get the message out of what's available today.
Thank you so much.
Thank you, Michelle, for that really good briefing. You always do a wonderful job, and you're doing a wonderful job running the program. Please keep it up. We're counting on you.
Thank you. Pleased to do it.
That ends the update on the reinsurance program. We'll now turn to the update on the Maryland Health Equity Resources Act of 2021. The panel will be led off by the Honorable Ed Casemeyer, Chair, Maryland Community Health Resources Commission, followed by Jackie Bradley, Chair, Health Equity Resources Community Advisory Committee, RFP Subcommittee, followed by Mark Luckner, Executive Director, Community Health Resources Commission. Senator, would you like to start, please?
Thank you, Madam Chair. Good to see you. I want to congratulate you on your announcement about retirement and wish you the very best in your future. As far as the committee, I just want to say that the commission was very pleased that you passed our the bill for the HERC and for trusting us in being able to administer the program. I just wanted to give you a very quick summary of what we've done in the past few months to get this program going, and Jackie and Mark will finish up with describing the details. First of all, the bill, as you know, is sort of broken into two parts. One, the pathway grants, which would last for 2 years and award almost $14 million in grants. And then after those grants expire in 2 years, we have the HERC grants, which will last for 5 years. And be for an amount of $15 million in grant awards. The bill called for us to form an advisory committee with various entities appointing members of the advisory committee. And that was done, we had our first meeting in August where the advisory committee met with the commission members. And at that meeting, we had, various legislators addressed us, the sponsors, Secretary of Health. But the main probably thing came out of that was the appointment of our 3 subcommittees. Jackie Bradley, who you'll hear from soon, dealt with the design of the RFP. Rebecca Altman dealt with the data that will be needed in the RFP to apply for an RFP and respond to it. And Elizabeth Chung would do the outreach aspect of the RFP. Those 2 subcommittees, not Elizabeth Chung's, because hers would be later, had several public meetings, virtually, obviously, whereby people, quite a bit of the numbers of the public called in to tell us what they thought should be in the grants, what would be needed to apply for the grants. Each of these subcommittees, Jackie's and Rebecca's, had at least 3 public meetings to gather this kind of data to construct the RFP. The RFP was ready to go. I guess it was October the 12th, I believe, that we put it out to the public. Soon after October the 12th, Elizabeth Chung and her subcommittee began a series of public meetings throughout the state. We went to Western Maryland, the Washington area, Southern Maryland, Baltimore, and the Eastern Shore. And we had live meetings in each of those locations where the public was invited to listen to what the RFP was asking for and answer questions. Then we had 5 virtual meetings over the same locations in case people weren't able to attend the in-person meeting. So all told, I think Elizabeth Chung's group had about 14 public meetings to respond to the public. The RFP, the response to the RFP was due December the 6th or 7th originally, and then, as you're aware, we had the little glitch with the health department's hack, whatever you want to call it. And so we had to delay the application process till the next week, this past Monday. And we were very, very pleased that up to this date, maybe we have some more, but when I say up to this date, some have come in late, and the Attorney General has to tell us whether or not they'll be acceptable because of missing a deadline. But not counting those, we have about 40 applications that have come in. So we're quite pleased. And actually, they're from all aspects of the state, all localities, and from different entities. So we think we did a good job reaching the public. We feel that the responses have been good, and that it's a bill that, again, we're very thankful that you sponsored, and it's a need in terms of serving underserved people out in the community, which there are many. So we have a PowerPoint, which I've sort of covered the first few pages. If you have any questions now or later, I'll be available, obviously. And I want to introduce Jackie Bradley now, who was on the Health Equity Resources Subcommittee Advisory Committee. Jackie?
I am unmuting.
Okay.
Thank you, Chair Sen Meyer. And thank you, everyone, for the opportunity to present to this committee. And I wanted to, if someone can move the slides for me, it would be helpful. So Chair Sen Meyer went through this slide.
Right.
Go to
You can go to bets number 7, 6 or 7.
Yes, it should be over to 7.
Right.
Okay, that's good. Right there. Okay. So as Chair Meyer mentioned, we had the call for the proposals, and that was released back in October. And as you're aware, because you did sponsor the bill as to the amount that we are going to be allocated for funding. And again, as he said, we did revise the date. The original date was actually December the 7th, and we had already received some applicants prior to that, the movement from the December 13th date. Next slide. And so the Maryland Health Equity Act really just wanted to, one of the things that we felt we needed to define for those that were applying for the grant was to ensure that they understood what health disparity meant. And everyone has a different definition of what disparity is. And so we really, during every meeting that we had, we were talking about the proposal, we made every effort we could to make sure that people understood that a disparity is, that there's a difference in the health issues, such as the ones that are listed here in the same population. So we wanted to make sure also that we were flexible with having those individuals selecting their health disparities, because we've got a lot of feedback from the various communities that one health disparity, for instance, in maybe my community, and the health disparity in another community is very different. One example that was used is, and it's not listed here, sickle cell. And so there is a community within our state that does have a high incidence of sickle cell. And it's important that we give them the ability to address that in their proposal. Next slide, please. Additionally, there was a lot of conversation around, what is an area of population, and and whether or not it would be a contiguous geographical area or just one area that may be with one zip code. And so we ensured that everyone understood that a minimal population would be 5,000 residents, and for them, for each grant proposal. And the important thing for us was that anything that they did was going to be measurable, and they would be able to document the disparity and the poor health outcomes that they have within their community, and hopefully be able to move the needle towards an improvement in the health. And so that, hence, we needed to make sure that it was going to be a measurable project. So we wanted them to be small enough to allow for, incentives on how various things that affect your health, aside from just having the disease, such as, racial, ethnic backgrounds, where the people live, and disabilities. Next slide. So the pathway HERC eligibility entities would be, of course, nonprofit community-based organizations, nonprofit hospitals, any institute of higher education, FQHCs, government agencies such as the local health departments. I think Chair Meyer did discuss the 14 meetings, and this slide just outlines the locations and how we did a statewide virtual kickoff with frequently asked questions in our virtual meetings, and then making sure that everyone had an opportunity to have their questions answered during these meetings, and some of them went rather long. Next slide. And so to date, I think this is Mark's slide.
You want to do it, Jackie? That's fine. You want to bring it home?
Okay. Okay. No worries. Thank you, Mark. And so right now we have 40 applicants, as Chair Meyer said, requesting $41 million, approximately $13 million to be awarded. We always ask for more, don't they? when we're trying to do something in the community. And so the applicants are from urban, suburban, and rural communities, and 15 of the applicants targeted prior health enterprise zones, such as Baltimore City, Eastern Shore, and Prince George's County. The breakdown for the applicants are listed below, with 23 being nonprofit community-based organizations and 6 hospitals, 2 higher education, and 5 FQHCs and 4 government agencies. I want to stop there for 1 minute and just make a comment, is that we did also encourage them to partner with each other because, for instance, the historically Black colleges may be able to partner with one of the other organizations that may not have the bandwidth to collect data. And perhaps they could partner with them, or an FQHC might partner with a local health department to ensure that their data collection is on target. Next slide. And so the timeline for the pathway grants are, the proposals will be, now that we have them, we'll start our review and we'll review them over the next few weeks. Mark and his team developed a really nice document that will score the applicants. And then we would take the top scoring applicants to come and present to us in early January or late January, early February. And then the decision will be made as to who will be the grantees. Next slide. And so these are the contacts for Mark's department. And we stand ready for any questions that you, Madam Chair, or anyone on the committee would have for us. And thanks again for the opportunity.
Thank you, Jackie. Madam Chair, if I may comment, Jackie mentioned that we had a kickoff meeting a statewide kickoff meeting back in October. And amazing, we had 372 people on the Zoom call that day. It was quite remarkable. So thank you for listening to us. We'll be glad to try to answer any questions you may have.
Did Mark have anything to add? We have him listed, and he certainly is welcome to speak.
I'm happy to answer questions. Thanks for that, Madam Chair.
Okay, thank you. Are there any, I see Steve Johnson has a question. Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for coming and making your presentation to us today. I have a question about the 5,000. A question was asked last year about where we came up with the 5,000, and in some of the rural areas, that's a little more difficult to help folks. So, and you were supposed to look into that. Have you made any progress or looked into that at all?
Well, Mark I'm sure will comment, but if it needs to be, we combine zip codes,
right, so
that we identify 5,000 people. It may take several zip codes to do that, but Mark may want to add on to that.
Thanks for that. Thanks for that, Mr. Chairman. Thanks for that question, Delegate Johnson. I might suggest, Delegate Johnson, in addition to the PowerPoint, we submitted a list of the folks that applied. So what that will show is that for the applicants from rural communities, they did, as you said, they combined adjacent zip codes to reach that 5,000 threshold. But I think the overwhelming response rate across the state, which, as Chair Casemar said, is from urban, rural, and suburban communities, shows that the language of House Bill 463 that you approved last session was sufficient to garner applications from across the state. You're right, some of the zip codes in rural areas are smaller than some of the other parts of the state. And that's why, as Jackie said earlier, we encourage in these public comments or these public outreach meetings we had across the state to partner and to reach across different zip codes to make sure they met that 5,000 resident minimum. And I think the data here, the fact that 40 applicants applied, many of which are from rural areas, shows that 5,000 threshold was not a deterrent in having robust participation.
All right, thank you. Thank you, Madam Chair.
Thank you. I see Delegate Melnick, who seems to be here. I thought you were at another meeting. You're next.
Thank you. Thank you so much. I just want to say thank you for the efforts that you made in getting the word out into the community. I know that I represent Prince George's and Anne Arundel County, and I put everything that you were sending out, and you even allowed me to come out when you were holding the information session. So I just want to thank you because you did make a great effort. Thank you for your work.
Thank you for helping.
Delegate Hill, followed by Delegate Rosenberg.
Thank you, Madam Chair. First of all, I wanted to commend you, Chairman Meyer and Jackie and Mark and the team for doing a really effective and efficient job. But my question, Mark, is for you, the grading or the rating of the 40 applicants, is it blinded?
Thanks for that question, Delegate Hill. Appreciate that. So what we do, and I'm happy to give you a copy of the list of the review criteria. It's very important that we have a thorough and transparent process. So in the call for proposals, which I'm happy to give you a copy, it's also up on our website. It lists the 9 or 10 review criteria. And as you know, we've been at this for a while, awarding competitive grants. And so I feel that 100-point scale works pretty well. So we assign certain points for each of the criteria. And earlier in the presentation, during Chair Casemar's remarks, he talked about the objectives of the act, which you guys will remember. There are 5 objectives in the act, in the bill that you approved. And so each of those 5 objectives, which include reducing disparities, improving outcomes, expanding access. I'm doing this from memory. Improving access to primary care, primary preventative services, and number 5, reducing hospital costs. Each one of those 5 is worth a certain number of points, because that's the vision that the Health and Government Operations Committee had in House Bill 463. There are other review criteria in the bill that they put in there into the RFP, but the long and short of it is that each proposal be reviewed on those criteria. Specific to your question, is the review blind from the applicants? No, the review is not blind, because you'll remember at different parts of the bill, which let me just go sideways and for a minute, thank the Health and Government Operations Committee, in particular Council, for drafting such a clear bill that was easy for us to follow, a nice legislative roadmap. There's language in there that encourages us to use, in addition to those 5 objectives, geographic diversity. So we want to try to have geographic balance in the proposals that are selected for funding. And so for that reason, we don't intend to use a blind review of the applicants. We want to know who they are, where they're coming from in the state, and what their history is in terms of working with the target populations.
Thank you. And Madam Chair, may I ask a question of the chairman?
Yes.
Thank you. Senator Meyer, as you said, the way we put the bill together, we have to the 2 years before the other. Were there some things that the General Assembly did not give you all the authority to do, that now that you started the process, you would like to have or would like to have had the authority to do?
Well, there are probably a couple of small things, not all that come to my mind at the moment, but the one probably obvious situation that we think should be amended is the fact that the way the bill's written, the HERC grants, that RFPs in the bill is supposed to go out in this November of 22. And we feel that should be pushed back, because here we're just awarding the pathway grants in February of 22. And if we award or begin to put the RFP out in November, the pathway grants will hardly have had any time at all to get their program going and see how it is working for each applicant. So we would suggest that the HERC awards be put off for maybe a year, so we're in that area, so that the pathway applicants will have a longer runway to develop their program before we award the HERC grants. That would be, to me, the obvious suggestion that we have. There may be some other ones, but aren't as significant as that one.
Thank you. Thank you, Madam Chair.
Very welcome. Delegate Rosenberg.
Thank you, Madam Chair. If I read the chart correctly, recall it correctly, the request for funding, I think, was about 3 times what's available for funding. Is that determined by statute, or is that governor's discretion? And is it your view, or is it premature as to whether that number should be increased in the coming year or years, given the demonstrated need?
Well, the 14 million that's in the bill is, fixed in terms of that's all we have. And actually, it's not even 14 million because there are expenses that CRISP have and other administrative costs. Mark may want to comment more on that, but that's probably something you should be deciding. But as you said, there's $40 million of requests for a little over $13 million. Mark, you want to comment?
I would just agree with you, Mr. Chairman. The 14 million is fixed in the bill, and folks will remember the 14 million originally came from the Relief Act that the General Assembly approved. And then the second piece of it is 45 million for the longer term Health Equity Resource Community HERC grants that you talked about earlier, Mr. Chairman. So, Delegate Rosenberg, thank you for the question. We're just really grateful to have the 14 million to distribute. And if there's will in the administration and the General Assembly to increase that figure, then we'll be ready to distribute increased funding.
Okay, I have one last question, and this is of Ed. My question is, you talked about the hack, the health department hack, and how it caused you a week of delay to be able to submit. Could you explain to me exactly what you meant by that? Is that you couldn't submit through a portal or something?
Yeah, maybe hack was the wrong term, but the problem that we were concerned about was that, probably most applicants would have finished their work by the Friday before the health department had a problem, but you can't assume that. So what concerned us was that on Monday morning, if someone was still trying to put together something, information was not available to those applicants who may have sought information that Monday morning. And again, just to be safe, we felt that we should give them extension, give them the benefit of the doubt that maybe someone was trying to get information from the health department resources that they could not access. And then later in the week, the other issue were health departments. Evidently, health departments, and Mark, please correct me, store their information on a network, a specific network. They all store their information in the same place, and that network was not available. So that anything they had, any health department now, only health departments, anything they had stored on the network was not accessible in terms of retrieving it. So that also presented a problem for specifically any health department who was intending to apply. So that was sort of our situation.
And did the extension, was that adequate? And has everybody now been able to access whatever information they needed to?
To my knowledge, yes, but Mark, do you want to comment on that?
Yeah, no, everything you said was accurate, Mr. Chairman, and just on your question, Madam Chair, people seem to appreciate the extension. We acted pretty swiftly. I think you have someone from the department, Deputy Secretary Hsu, he may know a lot more about all of this, but the way it impacted us at the commission is we put up all this information on our website, like data files that Chris prepared, 5 or 6 other documents. You go to the website, you download them, you do your work, and then you submit them. Well, that was not available the last, 2 days prior to the deadline. And as Chair Casemeyer said, if people were working on the applications, the good doobies, as it were, throughout the month of October, November, and they saved it on the common drive, like a local health department would, well, you can't access that information. So in some cases, health departments had to redo their applications from scratch. And so when we were grappling with what is an appropriate time extension to give folks, we thought about maybe Friday, maybe a little bit later this week, but we knew we were presenting to you. So we want to have accurate figures for you. So, Chair Case-Meyer sort of put on his Solomon hat, and we came up with Monday, which was close to a full week extension. And the two health officers that I spoke with were very grateful for that 6-day extension. And to my knowledge, no one's contacted us saying that they were not able to submit a proposal because of that network incident.
Okay, thank you very much. That's what I needed to hear. Okay, that ends this portion of our briefing today, and we appreciate very much the good work that you're doing and the
Thank you.
important work that you're doing. Please keep it up, and it's nice to see old friends back in front of us as well.
Thank you, Madam Chair. Good to see you guys. Bye-bye.
Thank
Bye.
you. Have a great afternoon.
Thank you. Next, we will hear from Steve Shue, Secretary for Healthcare Financing and Medicaid, Maryland Department of Health. Steve? Are you there, Steve? Hello? Richard, is Steve Shue in the room?
Yes, he is.
Oh, there you are. We don't hear you. You need to unmute, or we need to unmute you, one or the other.
Yeah,
We're
as of
still
right now,
not
he's
hearing you
unmuted.
yet. Steve, we don't hear you yet. Richard, have you
Mute on
done
your
everything you
device and
can?
Not the mute on your Zoom. It may be the device itself and not the Zoom mute.
Yeah.
Richard,
there's
you've
nothing I can
done,
do on this end.
okay. Steve, this is apparently about your computer. We still don't hear you. And if worse comes to worst, you could log off and log back on. Sometimes that solves problems. Did he log off, Richard?
Yes, but he's now in the meeting again.
Good. Let's hope this works. How are you? We still can't hear you.
How about now? Can you hear me?
Yes.
All right, success. I apologize. There are a variety of microphone options, and sometimes they get wonky on me. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, I'm Steve Shue, Deputy Secretary for Healthcare Financing and Medicaid here in the Maryland Department of Health. Thank you for inviting me to provide an update on our progress related to the work of the Maryland Commission on Health Equity. As you are aware, Senate Bill 52 and House Bill 78, which passed during the last session, established the commission, which became active on October 1st. The mission of the commission is to make healthcare more equitable for the recipients of care and for the providers that administer care, and to combat the disparities that currently exist here in Maryland. Recognizing the importance of this initiative, NDH began working to stand up the commission over the summer. The Secretary and I spoke with the bill sponsors, Senator Washington and Delegate Melnick, to get a better understanding of their vision for the commission and how best to achieve that mission. We immediately began recruiting talented and well-respected individuals to serve as commission members. The commission is designed to be an interagency coordinating council to address health equity and to eliminate health disparities, and is therefore comprised of representatives from all relevant state agencies, as well as external stakeholders with subject matter expertise. In addition to the commission itself, there will be two subcommittees, a data advisory committee and a health equity policy committee. The Data Advisory Committee is tasked with making recommendations on data collection, needs, quality, reporting, evaluation, and visualization, and developing, maintaining, and utilizing a health equity data set as defined and approved by the full commission. The Health Equity Policy Committee, which is different, will advise the commission on employing a health equity framework, which is a public health planning framework for addressing health disparities. Next, I want to provide you some information on the administrative elements of the commission and its members. The governor appointed me as chair of the commission effective October 1, and I'm very honored to serve as lead of this critically important work. Delegate Sample Hughes and Senator Washington have been selected to represent the Maryland General Assembly on the commission. I'm delighted to be working with them. Although not officially on the commission, I'd also like to recognize Vice Chair Pena Melnick, who has been a great partner throughout this process. She's provided guidance and insight on development of the commission. She's helped us recruit members and just been generally terrific along the way. Several staff from MDH will be supporting the commission, including Dr. Jeff Wolford, Assistant Secretary and Chief Medical Officer, who will serve as chair of the Data Advisory Committee. Dr. Noel Brathwaite, whom you know, the Director of the Office of Minority Health and Health Disparities, who will serve as a senior advisor and will assist with the work of the Health Equity Policy Committee, and who agreed yesterday to serve as chair of that committee, I'm pleased to say. And Heather Scheck, Director of the Office of Governmental Affairs, who will assist with reporting to the General Assembly. And last but not least, Mary Ann Gibson, my former colleague at the Opioid Operational Command Center, Deputy Director, who will be providing staff support. Additionally, representatives from all 26 of the state agencies named in the legislation to serve on the commission have been designated. A complete list of commission members, as well as information on upcoming meetings, minutes, other important information pertaining to our work, can be found on the commission website, which is health.maryland.gov/MCHE. So health.maryland.gov/MCHE, pretty simple. The commission held its first meeting on October 18th. During that meeting, Secretary Schrader provided opening remarks, reiterating the department's commitment to addressing issues related to health equity and acknowledging the significance of the work of the commission. We level set the members, reviewed roles and responsibilities, and discussed the scope of work for both supporting committees. And then we heard three excellent special presentations related to our work. Dr. Kim Sidnor, who is Dean of the School of Community Health and Policy at Morgan State, presented a health equity framework that she has developed in collaboration with members of the Minority Health and Health Disparities Steering Committee. Dr. Keisha Pollock-Porter, Dean of Faculty and Professor at the Johns Hopkins Bloomberg School of Public Health, presented on recommendations from the Health and All Policies Work Group, which was a legislatively mandated group that preceded the Maryland Commission on Health Equity. And finally, Dr. Yolanda Agbolu, Associate Professor in the School of Nursing at the University of Maryland, Baltimore, provided an overview of the Social Determinants of Health Task Force, another legislatively mandated work group that's charged with addressing social determinants of health in Baltimore City. So as you can see, there are many statewide initiatives underway that are focused on health equity and the social determinants of health. We intend to ensure that these different initiatives are coordinated to leverage the good work that is already underway to eliminate health disparities across the state. As I mentioned a second ago, there are two subcommittees within the overall commission, the Data Advisory Committee and the Health Equity Policy Committee. We're currently working on finalizing the members for both of these subcommittees. We're vetting applicants at this very moment, and we anticipate that those supporting committees will meet for the first time in early to mid-January. These meetings will be open to the public, and information on each subcommittee will be updated on our website. Lastly, I wanted to give you information about our next meeting. The second commission meeting will take place on Tuesday, January 11 at 1 p.m. The meeting will be held virtually and is open to the public. Viewing information can be found on the website. We'd be delighted to have any of you join us. During the next meeting, we're going to hear from the Health Services Cost Review Commission, the HSCRC, on the relationship between the commission and the statewide Integrated Health Improvement Strategy, or SIHIS, and from the Maryland Primary Care Program on its efforts to ensure health equity is integrated into their work. They are, by the way, Madam Chair, doing a tremendous job. I commended them this morning on the work they're doing in this area. It's really, really cutting edge. We also requested that each state agency represented on the MCHE, the commission, come prepared with any health equity related initiatives underway in their departments so that we can begin inventorying existing efforts in an attempt to streamline current activities, reduce duplication, and utilize our state resources in the most effective way. I'm hoping to have that information in the next few weeks. It's really important that we understand the full, get a full picture of what's going on across the state. There is a lot going on. That concludes my update on the Maryland Commission on Health Equity, and I'd be happy to answer any questions. Thanks again for having me and for your time.
Thank you very much for being here and presenting to us today, Steve. We appreciate it. I forgot to think about whether you were a senator or a delegate, or whether I called you county executive, but deputy secretary seems to work. But let me just be sure that you don't feel that you were not respected for your honorable position that you have had in the past.
Oh, that's so kind of you to mention. I'm happy to go by deputy secretary, but Steve works best of all.
Okay, well, we're happy that you're working cooperatively with our members and with the community. That's the important thing about this. I do see a hand raised. Delegate Melnick.
And I will be short, Chairman. I just want to say thank you, Steve, for your work and for reaching out to our office and including us. I really appreciate it. You know, you have truly made an effort, and I'm grateful.
Well, thank you. And the appreciation is reciprocated because, as you know, we had a hard time staffing up, and despite a lot of outreach throughout the state, and it really wasn't until you got engaged that we were able to fully staff. So we really do appreciate your engagement.
We have great resources in HGO, and we're happy to work with you to make these programs work. So you make sure that you remember us, okay?
Well, absolutely.
Okay, seeing no questions, I think that's going to end the briefing today. And the next time I see you, as far as I can recall, and staff can correct me if I'm wrong, will be opening day of the General Assembly session. Is that accurate? Okay, look forward to seeing everybody in person then. Have